Hi, good night. My name is Dr. Caitlin Butram, and I'll be presenting tonight on CSF anatomy and physiology. So what is CSF? Cerebrospinal fluid is a clear, colorless ultrafiltrate of the plasma that surrounds the brain and the spinal cord. It is contained within the ventricles and the subarachnoid spaces of the cranium and spine. CSF volume measures approximately 150 milliliters, 125 being within the subarachnoid spaces and 25 mils within the ventricles. So what are some of the functions of CSF? Some of the functions include it acts as a shock absorber, cushioning the brain against the rigid confines of the skull. It facilitates buoyancy, reducing the effective weight of the brain from approximately 150 grams to 50 grams. It also facilitates nutrient and electrolyte balances as well as waste clearance. So in terms of embryology, the timing of the initial CSF production remains unknown. Neurulation in week 4 encloses amniotic fluid within the neural tube, forming the first CSF-filled cavity. Flexion of the neural tube and regional cellular proliferation generate the ventricles, which gradually expand, and around week 7, the choroid plexus begins to form. The subarachnoid spaces also emerges around week 7 and becomes externally sealed by tight junctions between the arachnoid epithelial cells. Communication between the ventricles and the subarachnoid space begins with the formation of the foramen of Magendie at month 4 and the foramen of Luschka at month 6. The arachnoid villi begin to form approximately 35 weeks with continued maturation throughout the first 18 months of life. In terms of anatomy, 80% of CSF is produced by the choroid plexus, which covers 2 lateral ventricles, as well as the roof of the 3rd and the 4th ventricle. The remaining CSF is produced by the ependymal lining of the ventricles. It's also produced in the spine within the dura of the nerve root sleeves and the interstitial space. Around 500 mLs of CSF is produced each day, with 50 mLs being present in the body at any given point in time, and it's produced at a rate of 20 to 25 mLs per hour. So production of CSF. CSF is produced by active secretion of the choroid plexus epithelial cells. And the choroid plexus is made up of 3 structures, this being the fenestrated capillaries, which allow plasma to leak out, connective tissue, which is the pia mater, and epithelial cells, which is the modified ependymal cells, connected by tight junctions. And this brings us to the blood-CSF barrier. So the blood's cerebrospinal fluid barrier is a selective barrier at the choroid plexus that regulates the movement of substances between the blood and the CSF. It's formed by a single layer of the choroid plexus epithelial cells joined together by tight junctions, which controls the CSF composition and protects the central nervous system. It contains numerous ion channels and transporters for glucose, vitamins, and other substances, regulating ion gradients and the composition of the CSF. And the tight junctions also limit the entry of immune cells and pathogens from the blood into the CSF. This is just an image showing the tight junctions. So it's a step-by-step process. So the plasma is firstly passes through the fenestrated capillaries into the interstitial space of the choroid according to a pressure gradient. Active transport from the interstitial compartment to the ventricular lumen across the choroidal epithelium involving carbonic anhydrase and membrane ion carrier proteins. Some of the ion carrier proteins that take place in this process, sodium is actively secreted back from the apical membrane by the sodium-potassium ATPase at a 3 to 2 ratio. Carbonic anhydrase converts carbon dioxide and water into carbonic acid, which dissociates to give bicarbonate and hydrogen ions. The hydrogen ions promote sodium reabsorption via the sodium-hydrogen exchange channel at a 1-to-1 ratio. And the bicarbonate and chloride ions are also pulled across the membrane by sodium co-transport. And this is just a diagram showing some of the ion transport channels. So the influx of iron into the cerebrospinal fluid results in a presence of osmotic pressure gradient, enabling transport of water by aquaporin channels, which are located on both the basal and the apical membranes, which we could also see in this diagram. So the composition of CSF. The main component of cerebrospinal fluid is water with 99%, with the remaining 1% made up of protein, glucose, ions, vitamins, and neurotransmitters. The composition of cerebrospinal fluid is very similar to that of plasma, except for the difference in the protein and the ion concentration. So some of the things that contain blood proteins, such as albumin, immunoglobulins, leptin, prolactin, vitamins such as ascorbic acid, folate, thiamine, the ions which we just mentioned before, and some of the proteins that are synthesized within the choroid plexus, such as transferrin, insulin growth factor. So the flow of CSF. CSF circulates within the ventricular system of the brain. Majority is produced within the lateral two-thirds of the two lateral ventricles. From here, CSF passes through the interventricular foramen to the third ventricle. This is also known as the foramen of Monro. Then it goes through the cerebral aqueduct to the fourth ventricle. From the fourth ventricle, the fluid passes into the subarachnoid space through four openings: the central canal of the spinal cord, the median aperture known as the foramen of Magendie, and the two lateral apertures known as the foramen of Leschka. This is just a diagram showing the flow of the CSF. So it's a CSF reabsorption. There are three recognized routes through which CSF exits the subarachnoid space to enter the cerebral venous system. First one being arachnoid granulation, second being channels that pass through the cribriform plate of the ethmoid bone and the lymphatic system. Majority of the CSF is absorbed into the dural venous sinuses by the arachnoid granulations. It exits the subarachnoid space by diffusing through the walls of the arachnoid granulations. The arachnoid granulations provide a valvular mechanism for the flow of CSF, which allows the inflow of CSF into the bloodstream without permitting the backflow of blood into the CSF. And the highest number of arachnoid granulations are found in the superior sagittal and transverse sinuses. So propulsion of CSF along the neuroaxis from the sites of secretion to the sites of absorption occurs primarily through rhythmic systolic pulse waves transmitted via the choroidal arteries. But some other factors promoting this flow could be respiratory frequency, body posture, jugular venous pressure, and circadian variation. This is just a video demonstrating the flow. So in terms of regulating CSF, corticosteroids may reduce the activity of the sodium-potassium ATPase, which consequently reduce the production of CSF. Carbonic anhydrase inhibitors such as acetylcholine could also be used. Furosemide inhibits the sodium, potassium, and chloride co-transport, which reduces ion transport, thereby decreasing the osmotic gradient for water movement, also reducing CSF production. As well as vasopressin could be used. It acts on the arteries of the choroid plexus, and constricting these vessels could reduce the blood flow to the choroid plexus, thereby also decreasing the volume of circulating CSF. Drugs such as thiopental, midazolam, and ethylmidate could also reduce CSF secretion by reducing cerebral blood flow and cerebral oxygen metabolism. On the flip side, substances that stimulate CSF production include ketamine and enflurane. Ketamine mechanism of action is to increase cerebral blood flow, while enflurane increases choroid plexus metabolism. So in terms of clinical correlations, lumbar punctures are a commonly performed invasive procedure which CSF is withdrawn from the subarachnoid space. It is used to measure intracranial pressure and to obtain CSF samples for diagnostic evaluation. A sterile spinal needle is inserted most often between the levels of L3 to L4 or L4 to L5 interspaces into the subarachnoid space where CSF is collected. For the normal CSF parameters, color is clear, opening pressure is 8 to 15 milligrams. The glucose concentration is 50 to 80 milligrams per deciliter, protein concentration 15 to 45 milligrams per deciliter, and a mononuclear cell count of 0 to 5 cells. So this is just some of the parameters being compared to if a patient may have a bacterial meningitis, a viral meningitis, or subarachnoid hemorrhage. Some of the differences include bacterial the color might be turbid, there'll be increasing protein and decreasing glucose, subarachnoid hemorrhage, it might appear xanthochronic. So in terms of a CSF leak, it's a condition where CSF escapes from the subarachnoid space through a defect in the surrounding dura mater. It's usually classified into traumatic, which is the main cause, craniofacial. It could be iatrogenic, 16%, due to something like endoscopic sinus surgery, or it could also be spontaneous or idiopathic, which is like a dural tear or meningeal diverticulum. Can also result in spontaneous intracranial hypertension if it's a significant leak. Patients commonly present with orthostatic headache, which begins or worsens upon standing and improves with recumbency. So patients may have CSF rhinorrhea or otorrhea. The dural tear results in communication between the subarachnoid space and the middle ear or the paranasal sinuses. A clinical diagnostic evaluation we could do is a halo sign. So drops of the leaking fluid could be put on a piece of gauze or paper, and a rapidly expanding clearing around the fluid surrounding blood could suggest the presence of CSF. However, more confirmatory diagnostic tests would be to test for beta-2 transferrin protein, which is only found in CSF and perilymph. Some CSF leak precautions that we would advise: bed rest with head elevation to 30 degrees, avoid straining such as blowing your nose, sneezing, or straining with defecation. Non-surgical management is usually sufficient if it's a small to moderate leak. Most resolve without complication within a week's time. However, surgical management for large or persistent leaks would include transcranial or endoscopic repair and/or CSF diversion. And lastly, we'll just talk about hydrocephalus. So hydrocephalus is a significant clinical disorder involving abnormal accumulation of CSF within the ventricles, typically resulting in an elevated ICP. Most cases result from impaired CSF reabsorption, and it can be categorized into two functional subtypes: obstructive or non-communicating, and non-obstructive or communicating. Obstructive hydrocephalus arises from a physical blockage in the CSF flow proximal to the arachnoid granulations. Examples include aqueductal stenosis, intracranial mass lesions. Non-obstructive hydrocephalus occurs when CSF reabsorption is impaired at the level of the arachnoid granulation without any discrete obstruction in the ventricular flow. These etiologies could also broadly be classified in congenital or acquired. Congenital causes include chiari malformations, X-linked hydrocephalus, primary aqueductal stenosis, and Dandy-Walker malformation. Acquired hydrocephalus may result from infection, most common cause being this is one of the most common causes of communicating hydrocephalus. And the treatment of hydrocephalus involves addressing the underlying obstruction to the CSF flow. Diversion of the CSF through a shunt system may be necessary when the obstruction cannot be resolved. Thank you.